to yours, but like different versions.
Oh, I saw that with the billing, right?
Huh?
Are you doing the same thing I'm doing just with billing?
Yeah. So, we don't. We are being reported here.
Good job. All right, I'm going to do the billing then. Since you're doing that.
Talking to yourself. I'm not sure what that means.
Both of them are real coffee, right?
It's real coffee.
It's real coffee.
Yeah, with all high octane stuff.
Keeps us good. So we're good at the door, sir? We're good at the door?
Yeah, there's two people from AstraZeneca there.
Okay, good.
I think that's who they're with. No, I'm pretty sure they're. It's interesting, sort of who cooperates. You've been consistent all the years, but the ups and downs of the pharmaceutical industry sort of indicates. Oh, people are recording this.
It's being recorded that way.
Yeah. Never mind.
Just changes.
Yeah, changes is right.
Yeah, changes.
Changes depends on, Tillerson's out, and did you hear that this morning?
Yep.
Yeah.
I don't understand. I'll say this on the recording. I don't care what your politics are. The Republicans in Congress, I don't know how some of these people, a decade or 2 decades from now, when their children or grandchildren said, what did you do when that man was president to secure the future of our country? I did nothing. I just put my head in the sand.
What are you
Just
doing?
changing my presentation. I changed it a little bit yesterday. Because I did it in the airplane, so I had to make changes. They came back home and I said, oh my goodness, that's complex. Lots of typewriter here, lots of things here.
Did we get lunch at the aid?
Yeah, it should be.
I think so.
They said there's a lunch break. I don't know
Oh.
if there's a lunch served or there's a lunch break.
I hope they give us lunch.
I'm sure you'll get lunch, because it says at the end of the day, clean up the room, and so probably there's an all-day allergy and infectious disease retreat over at the Urban Horticultural Center
Yeah,
over by Sandpoint.
yeah.
So the fellows do the presenting there. There are a lot of ID fellows, but the 2 second-year allergy fellows.
Do that.
Yeah, so the reason Christina won't be here this morning is she has a presentation fairly early this morning.
Now, what about Dr. Tiller's presentation tomorrow at dinner?
I tried to help get an audience
Well-
for them, but I don't know if they're going ahead or not.
Well, I'm saying, I can be there if you'd like me to be there.
I'm not. I had nothing to do with arranging it. I just it's ALK.
Yeah.
Yeah. I mean, the person putting the thing together said to me the other day they didn't have a big enough audience to go ahead with the program.
Good morning.
So I tried to encourage people to come.
Well, I wasn't sure whether industry was invited or not. I know I got the invitation, but I wasn't sure.
Oh.
But I can make it. I mean,
Yeah, I don't know if it's going ahead or not. You might want to contact the rep and see if, I'm sure you know how these things are. By a certain date, you had to guarantee it.
Yeah, that's true. Yeah.
If you didn't,
Taha setting it up today?
No, he's fixing
All
his
right,
presentation.
I'll double check on that.
He said there were a few typos.
okay.
Taha typos? What?
Is somebody gonna come in again at like
Taha,
Frankly,
sit down. Your presentation.
It's
Q&A.
perfect.
a little bit,
Yeah.
you really shouldn't have used
Even with
stop
typos.
showing us that.
Yeah.
Orlando.
Is it okay with you guys if I go first?
I don't
You
care.
can't go first.
have to go
They
to
decided to
retreat.
keep you with us.
Huh?
They decided to keep you with us so you can be late for the AI retreat.
You know what? When you're told to be in two locations at the same time.
Unfortunately, there are some people that do that. Take advantage. Okay, so get in touch with whoever and see if it's still on.
Are they
Thank you,
gonna
sir.
come in at 7:45 and like close it? Because that was awesome the one time that happened. They said that a few times. Yeah. Like in the middle of the.
Len, is it okay if I go first?
Sure. Well, before me, I'll only take 5 minutes.
Oh no, yeah, after that.
I'm not going to take much time.
Okay.
And then you have to get over to that other meeting,
Yeah,
right?
yeah.
But you don't present until about 2 o'clock
Yeah.
today?
So you presented?
My newborn screening stuff that I've been doing in children's. Are you guys going to that retreat?
Yeah, just after this.
Oh.
Just be late.
I brought this incriminating picture by. Do you remember that evening?
Yes.
Oh gosh. Looks like you had some fun.
Yeah.
Oh yeah. There were no rides though.
They didn't let you go on the roller coasters? What is the point of SeaWorld?
Did you go up to any of the amusement park?
No, I did not.
I petted a little otter though.
Huh?
Okay, that's pretty nice.
Oh,
Just
really?
a little otter.
Oh yeah, you did that? I didn't.
It smells kind of bad.
It was not. You didn't like hold it.
No, I petted it.
Oh.
They didn't let me hold it.
There was some woman there holding it. So they didn't have any of the rides turned on.
It was blocked off.
SeaWorld though?
There's
There were-
definitely a roller coaster.
There was a couple roller coasters that I could see from my hotel.
Yeah.
SeaWorld?
Yeah.
Yeah, I mean, we really weren't allowed in SeaWorld. It's just a little confined area where they hold receptions.
Yeah.
So they could advertise it as being at SeaWorld, but really. You're
They
just
brought
kind
the
of
one otter to make you feel like.
Yeah.
The Dan said there was like an owl and something else too. But I didn't
Oh
see
really?
that. I just saw an otter.
The otter,
Yeah.
cutest one.
Otters are adorable.
It was the smallest. He said it's the smallest otter. It was like fully grown, but it was like this big.
Oh.
Oh, like a river one?
What?
Maybe it's a river one as opposed to like a sea otter.
It's
River
river
otters
otters.
too, I think. Yeah, not sure.
Oh.
My eyes kind of haven't.
Yeah. I feel like I lost my hour last night and this is Sunday.
Haven't gotten used to that yet.
Apparently I haven't. Well, I didn't have to
No,
get up
nor
as
I.
early yet. Yeah.
I was getting used to seeing the sun in the morning.
Yeah, right? It was so pleasant.
Now it was dark.
It was
I
so
didn't get your new
pleasant.
slide deck in there.
Oh. What did I?
I just saw the disclosure slide.
Oh, okay, maybe. Yeah, I could also just say I don't have any disclosure.
We trust you.
Oh, oops, I didn't make a disclosure slide. There.
Huh?
Funding from what AI? Are you supposed to say that?
No, I don't know.
He said you're gonna have to like list this in the future, but then they didn't even tell us where we're getting it from.
Well, I emailed them and I said, do I need to put the travel grant funding source on my poster? Because I would think that's the most relevant. But they said, no, not yet. So. I think Taha gave this travel scholarships, right?
I have no idea.
I thought so.
If we did kaboom. I don't think usually. I'm trying to think if you would need to put that on. Because it's like you got the money from technically the Quad AI, even if we gave it to them.
Yeah, I
send it by Friday.
I think that's the least of everyone. We're gonna target
for pickup, so they didn't even
see if they actually
They
the
put it in
fellows
box up.
disclose. Right. I mean,
Yeah, actually, I can't
I don't-
imagine if you got a travel grant, but the travel grant doesn't
I just
come from
figured
us.
it
It comes from the Quiet Eye, right?
Yeah,
Yeah,
it's still
through
good there. I
donations
just like
from
I'm sending like a $5
I was like,
plus.
I'm not gonna pay $5 extra for
Someone to sign. Well, like they would have to report it.
I didn't want to sign it, but I just it's like the kind of the envelope. Unless you have envelopes.
So I sent it to him. Or at least that's how I read that. I think if you don't give me my money, I'm not compliant, I have to send something to.
Yeah,
what are you guys talking about today?
the same thing that you're gonna talk about. So try to be brief, so
Really?
we can expand on a couple things.
I'll be real brief.
What is it?
I mean, do you know what are you talking about? We attend the same session, so probably there's high chance that we'll talk about the same thing.
What are you talking about?
You went to the Quality Eye, right?
I'm asking what are you talking about?
Oh, I mean, about some like thunderstorm.
What?
Oh, that's good. So nobody knows that.
There he is.
Thunderstorm. I'm not like that.
Crazy.
Oh, did you check if you're able to switch
Exactly.
the space?
Golfing? They open up the golf course for you?
I don't know any
Not more.
not like if you want, but I can like find you like some places toward the end. If you like, I don't know if that's something. It's totally like June.
Leave for a week and somebody takes your place.
Yeah. I don't know if you prefer that. That's fine with me. I mean,
Okay.
you know, I can find some other
I got
days.
place
But
next
like
to
during the
Mike
days
all
though, I
these
really
years.
need it. It seems like we're not available.
I'm real estate. He'd get lonely if I wasn't there.
But I'll see. We'll figure it out. I mean, don't worry about it.
It's yours, right? Yeah. My office.
Oh, it's only because I don't have like so much balls.
So get an epic pass and then shoot. And so now I'll be able to join
You know what? Because like I have vacations, like I just.
Did you go up there recently?
I just went like so many, like maybe like 1 weekend.
No new snow, but the groom snow is good, and they just added like 10 more resorts.
I will share it with you at the space.
Well, that's just it. Telluride's on it too.
Yeah.
So,
That's
Well,
fine.
Telluride opened this year on Christmas Day with 1 foot of snow.
is that right?
1 foot.
Well, I was in Colorado last week and it was pretty weak
Yeah.
as far as total amount of snow.
Yeah, Utah was doing bad too. They just got like 4 or 5 feet in the last couple of
Because I
weeks.
see like you want
They're Park
April, May
Cities
thing,
on it,
right?
so-
So,
Yeah.
an April, May thing.
Dan
like,
still lives there, my son, so he gives me the
Yeah,
progress report.
that's fine.
So Baker, as of last week, had 220 inches more than any other resort in the country. So we have all this big snow in our backyard. Baker sort of
I skied there once in
grungy place.
life at Baker. Have you ever skied there?
Nice. The meeting was
Actually, it was great. Opening day, like
busy.
just
Didn't
before
really
Thanksgiving.
do much outside.
There was-
Yeah.
No rides.
No ride.
But it's such a long drive. That's a
See, for
killer.
me, it's another 2 hours of
It was
whistling.
like not near where we were
No, but
staying.
I was
Yeah, that's true.
Plus
you got a place to sit.
Yeah. There are many places that stay near Baker.
And then
There's
there
one of those houses.
I would do it if I was.
So Mike, on those parking
Go for
Tesla,
the full
is that your
day,
white
but,
one
like,
in here?
it's impossible with the
Oh, yeah, you can park
company.
there. Yeah, you tell me
Go
that,
more
but I
than
don't have
half
a
a
Tesla.
day.
So
I don't think anybody else can come there before 8:30.
I found a parking place on the street right next to me.
For like $100 a day.
Yeah,
So you're gonna think I'm going to
Very much. I have a friend that
You know what? Yeah, I paid $2 here a couple times, and then one day they said, "Well, we can't do it." I went over there.
I
and
went
they-
out to Stevens on Wednesday.
I almost called you last Friday.
The Jason building. They
Are
said
you
we
gonna
can't
go
do
this
it here
Friday?
today. You have to go over there.
Oh, yeah.
Supposed to now
It's on
have
the snow. Why, you wanna go?
30 every time.
It was open.
Yeah.
No, this is sad.
Either that or we drag up to Whistler with snow. Why not?
I can't stay awake.
All right, let's go ahead and get started. This is usually a kind of informal session to discuss the new stuff that came up at the meeting. Just a couple of announcements before we get started. There's another session today for those who are interested. It's the reason Christina, one of the fellows, isn't here. There's an all-day retreat for allergy and infectious disease. dominated mostly by infectious disease, over at the Urban Horticultural Center with all the fellows in the program for presentation. So Jay has got a presentation at about 2 o'clock this afternoon. Yours is on the registry, is that right? The registry for SCID patients and what's come of that. Christina's got a fairly early presentation this morning, so she couldn't be here. The other thing is Param Nair, my friend from McMaster, who comes every year and is a fantastic and really brilliant man. He changed his date. He wrote to me while we were at the Academy meeting, so I think he's coming now May 8th, and that's a session not to be missed. So with the schedule, Jennifer Reagan's was nice enough to switch days with him. So just make note of that, because I'd like to get a good attendance for him, but if there's anybody for the whole year who's worth listening to, it's Param. So I'm just going to take like 5 minutes and give my overview impression of the meeting. And the first thing to comment on, this was a joint meeting between, the word of the day is Quad AI, just AAAAI. It was a joint meeting with the WAO, and I thought that had some implications on the quality of the meeting. I'm going to just not talk much about specific science, except one thing at the very end, which is then relevant to the fact that I'm a speaker and a consultant for Shire. The one thing I was going to mention is relative to a product that they will likely have on the market in a couple of months. So I gave the whole meeting a 5 over 10. The pros were there were warm, sunny days. It's a good but very large convention center. We had a nice turnout at the Pacific Northwest UW reception that we had on Sunday. And of course I could only go to, there are 4 or 5 competing sessions, so I went to things that interested me. I thought there were good sessions that had to do with food allergy. The last plenary session was all about food allergy. There were some good sessions about atopic dermatitis and immunotherapy. And although I didn't put it on the slide, one of the last sessions on the last day of the meeting was specifically about immunotherapy, and there were 2 very good speakers, Steve Durham from England and Hal Nelson, and they were basically giving their perspective on how Europeans practice immunotherapy and how we do it in the States, and also comparing SLIT and SCIT. And just Steve Durham's takeaway, having done a lot of the research, is that the 2 forms of therapy are about equal, which I don't think is the American perspective on that. I think, I'll just give you my bias, is that conventional subcutaneous immunotherapy in most studies is more efficacious. And then Hal Nelson discussed why the 2 nations here and all of the European Union practice differently. And there were some very interesting things. He did it in this extremely thoughtful, methodical way. And I thought there were 2 things that were important. One, in the States, the allergenic extracts that we all use for subcutaneous immunotherapy have to be standardized by the FDA and the federal government. In Europe, each company standardizes its own, and there is no European standard. And he showed the range of allergenic extract is much broader in the European countries. So it dawned on me, he didn't address this directly, that the reason that they see less efficacy from subcutaneous is they have some extracts that are maybe not potent enough to be effective, while oral immunotherapy, it is a standardized product with a known efficacy. The other thing that...
Did they, Len, show a map? I mean, in the UK where Derm is, do they have higher concentration?
He didn't show it by country. Just, just the country, like Allergens is, I don't know, headquartered where. So he didn't address that. He just showed quite a broad range compared to much greater standardization in the U.S. And the other thing that we've all known for a long time is he pointed out in European countries, most people are immunized, whether it's subcutaneous or oral, with one allergen. They just pick the dominant allergen. Maybe 10 or 20% of European countries will get 2 allergen immunotherapy. In the U.S., the average is 12. So really, apples and oranges, quite different the way that we practice here. And so I thought that was interesting and provocative. The third speaker in that session has to do more with the cons that I'm mentioning here. Many speakers hard to understand. This was a joint meeting with the WAO, so I think there was a requirement that a certain number of speakers be from European and other countries. And this is my ignorance as only an English speaker. Many of them were hard to understand. There were sessions. I think I asked Jamie at one point if somebody was speaking English, but I had no idea what was being said. The other negative, as you'll see in just a minute, there was, I thought, just an excessive emphasis on environmental issues. Virtually every plenary session was on environmental issues, and I think the reason for that is the guy who was president this year, his whole career has been in environmental issues. He's down at the National Institute of Environmental and Health Sciences, the one institute of the NIH, which is not in Bethesda, it's down in Research Triangle Park. So, I mean, specific to that point, the Friday plenary session, environmental impacts of asthma, talked about epigenetic changes caused by pollutants, efficacy of indoor home interventions. I think Taha's got a little information about this. That was the one session that I thought was pretty good in that session, and actually tells us fairly disappointing, the things that we tell people to do with indoor environmental control, with cockroach and dust mite. The European take on that is it's of almost no value. The American take on it has modest value. It depends exactly on what pollutants you're talking about. Interactions of pollutants with innate immunity. Saturday, more of the same. Asthma, allergy, and climate change, chemical and biologic pollution, effect of climate change on pollinization. And the last one, again, Taha, I think, learned more from this session than I did, talked about pollens and molds and severe asthma. And this, an Italian scientist, talked almost exclusively what must be his interest about epidemics of severe asthma from thunderstorms. Sort of uniquely focused on Melbourne, Australia, and an epidemic, which was fine, but I didn't think it really warranted a whole part of the plenary session. So my consensus was that was a terrible session. Sunday, more environmental influences on innate immunity. This was kind of interesting. I'd never heard this term before, trained innate immunity, which the best I could get out of this session was that if you stimulate monocytes, the whole talk was about monocytes, that epigenetic changes can occur. So if the cell is activated by one stimulus, it can then, not in an antigen-specific way, but just in an activated way, act against a second stimulus. So I would just call that, phagocyte activation, but the term for it, if I understood it correctly, is trained innate immunity. Then there was a whole talk about agricultural dust by someone from the Midwest. And then the third talk was fascinating. It wasn't really in the same theme, but a brilliant guy who's really talked about systems immunology and how to create, how to find medical answers and new therapy from existing open source data. So a guy trained in systems biology, trained in computers, also an MD, just gave us examples of how from all the existing database we have, they're finding new uses for old drugs, and he's founded a number of companies, and just a unique talk. It didn't really fit into that schedule. Then the last one was on food allergy. So that was the one plenary session that had a different theme, talked about the innate mechanisms of tolerance involving T reg cells, mast cells, innate lymphoid cells. That part of the issue there is reprogramming Treg cells to act like Th2 cells. Also, part of the development of food allergy has some data on dysbiosis or changes in gut flora. The second talk in that was about using component analysis that we now have for, say, peanut allergy and developing your tree nut allergy and diagnosis. And then the last one was more clinically related, the status of where we are with oral immunotherapy or the patch, and both of these things are being studied by Steve Tillis and folks over at Northwest Asthma, and that these things are reasonably close to clinical release. They're in phase 3 studies. The only specific thing I wanted to focus on was just 3 abstracts, because I am interested in this personally, but I think this is going to be the next biologic we have in our field. It's on expedited review by the FDA, and it'll be the first biologic that's not aimed at asthma. So that's why I said that I have some relationship with Shire, because Shire is going to have this product. So there were 3 abstracts, 150, 151, and 152. You can see the title. All of them had to do with looking at this monoclonal antibody, lanadelumab. I don't know what the brand name of that will be, but on the bottom, I just summarized it. It's a new biologic anti-kallikrein monoclonal that's administered sub-Q as prophylaxis for HAE. From what I can see of the data, this is going to totally change the way we treat people. There'll be much less need for products like C1 esterase replacement. The summary of all of those studies and different ways they did it is placebo versus 3 different doses of this drug, either given every 4 weeks or every 2 weeks. And in talking to Mark Riddell and others, they don't know how the FDA is going to approve it or how it will be used, but if you stratified their data in different ways, depending on the attack frequency of people before they got the therapy, the efficacy was between 51 and 93% in stopping attacks of hereditary angioedema. So I think the company believes this is going to be a blockbuster product, and as I said, actually, to my knowledge, the reason Shire bought its main competitor, Diax, was to get access to this patent. They weren't particularly interested in the rest of the company, but they knew that this would be a big breakthrough product. So that's all I was going to talk about. Jay wants to go next because he's got to get over to this other session that I was mentioning, and then we'll go from there. But any other comments from people who attended the meeting about my synopsis on it? Many people didn't attend, and as you can tell from my synopsis, I'm not sure you missed.
How fast does this new molecule work, Lynn? How fast does this new molecule work? Can you use it for acute treatment, or is it just for prophylaxis?
Not for acute treatment.
So you can't use it in the ER then?
But none of the studies have addressed that. I don't know the answer to that. I mean, Firazyr seems to me to be such a good product for acute attacks that the combination of those two, except for price, almost solves the disease.
That was the question.
It's interesting just how the value of scientific discovery, knowing that the biology of this disease, kallikrein and bradykinin, and knowing that it's not a histamine-related disease or a complement-related disease, has led to all of this. When we used to think that C2 kinin or other things caused this disease, it wouldn't lead to this product development.
All right, so I was going to talk mostly about my abstract, and one of the things leading into that was one of the first sessions on difficult cases I went to on severe asthma was mentioning the use of different biologic therapies that we have right now. And actually mentioned the combination use and how it's not been documented apart from the case report that Matt and Jake put out last year. So I found my abstract is I have no disclosures, but my abstract is an extension on that. A couple more cases that we've treated here at University of Washington, and don't worry about reading this. I'm going to kind of go through it throughout the next couple of slides, but essentially we used omalizumab and mepolizumab in combination in 3 patients with ABPA, 2 with severe asthma, and 1 with ciliary dyskinesia. So just a little bit about ABPA. So it affects 1 to 2% of patients with persistent asthma and 2 to 9% of those with cystic fibrosis. And the incidence seems to be increasing, and I think there's more recognition now of the actual disease as well. And it's characterized by eosinophilic pneumonia, bronchiectasis, you can get granulomas, mucus impaction from an allergic inflammatory response to aspergillus that spores germinate in the lungs. And we actually don't know why these patients with asthma and cystic fibrosis are particularly more susceptible, and what predicts, and we're starting to learn more, but why certain patients with asthma in the same environment might get ABPA, but others don't get ABPA. So there needs to be aspergillus, which is almost everywhere, colonize the airways, and then there's this Th2 inflammatory response with multiple different cytokines and eosinophilic inflammation. And one of the other thoughts is that in these patients, they have a hyperresponsiveness to the cytokine production. Diagnosis, there's no clear, there's some a consensus that is some of these things, but and these patients do have peripheral eosinophilia, an elevated total IgE, and the elevated total IgE can be used to monitor patients' response to therapy, so it does go down with treatment with steroids, and then either elevated specific IgE to aspergillus or skin prick testing to document sensitization to aspergillus. And then imaging is not specific. It's typically characterized by central bronchiectasis, but you could have multiple other things seen on imaging as well. So it's hard from imaging alone to say this is ABPA. So it's not very specific. And then on PFTs, on spirometry, you typically have airflow obstruction and reduced FEV1.
I'm just curious, I have one patient that I followed for years. This is not a common disease in the Northwest. Other people in the room have patients with this? It's a Midwest disease, right? It's first described in the Midwest, and I don't know if that's because of farming communities, but we have farms here. But
3.
So the treatments for ABPA, initially for a while all we had was steroids and itraconazole and voriconazole, and steroids, these patients do initially respond pretty well to steroids, but often will require high doses of maintenance steroids to put their disease into remission. And we've, at least in our experience, not had a great response to the antifungals, and the thought is by treating with antifungals, you can decrease the amount of aspergillus and try to decrease the inflammatory response, that reaction to the aspergillus that way. But omalizumab has been shown in the last decade in a couple of studies to have some efficacy, and from what I was reading, that they've used it even in patients beyond the typical dosing that is seen in asthma, and but anti-IL-5 medications have not been documented in this population, although these patients would qualify under a severe asthma and peripheral eosinophilia diagnosis. But so Matt and Jake actually put out a case study, which that will be my first, one of the first of 3 cases I talk about, that responded quite well to mepolizumab with omalizumab. And the reason why in this patient, which is the one they put out in the case study, why mepolizumab was started is the patient actually had an initial good response to omalizumab with decreased symptoms about a month after starting, but then her disease got worse. So with the literature out there, it wasn't clear if she, and it was thought that she might have had some benefit from the omalizumab, but needed something else, and that's why she was started on mepolizumab later on. And she had a quite dramatic response because her FEV1 was quite diminished, and that didn't really change, but she was able to come off oxygen. She was able to do a little bit more of her activities of daily living, but she had pretty end-stage lung disease and had been talks about lung transplant for her. And this also helped taper the maintenance steroids. And the second case is a 92-year-old male who also had severe asthma and ABPA, and he couldn't tolerate systemic steroids due to steroid-induced pancreatitis during one of his episodes, and that was a while back. So he was started on omalizumab, and he also had decrease. And unfortunately, I don't have the spirometry to see kind of what that changed between starting omalizumab, but overall his FEV1 improved after starting mepolizumab about a couple months into his course. And the reason why, again, it's similar with the last case, mepolizumab was started, was he had some improvement, but then continued to be symptomatic despite the use of omalizumab. And I forgot to mention, all these patients had been treated with itraconazole or voriconazole. And his FEV1 would actually improve from 53% to 64% predicted. And then the last one is a 58-year-old female with ciliary dyskinesia and bronchiectasis, and had the diagnosis of ABPA from the workup shown here. And she also had a partial improvement after starting omalizumab, and just by symptomatically. But then had a disease flare and started mepolizumab, and she also reported pretty significant symptomatic improvement as well. So these are 3 different cases, and a lot of the questions I got at the Quad AI was actually, how did we get these patients covered the medication?
Right, yeah.
And you know, it's a tough thing, and I talked to Matt because I think he was in the trenches of these patients. Matt and Lahari had followed these patients, and we've had about probably a 50% success rate, so we do get quite a few patients denied. And I think the first one, Matt was saying that the insurance company didn't realize that the patient was already on omalizumab and had started mepolizumab. So, but it remains to be a challenge, and it's something that, you know, probably is going to come up more and more, the use of dual biologics, just from talking to different people. You know, I know Jeff Demain has a couple of his severe asthma patients up in Alaska. We talked to him. So there's definitely providers around the country have a couple very difficult to manage, and some have been able to get the patients on dual therapy. And these were just for ABPA and severe asthma or the ciliary dyskinesia, but some people are also using it for just severe asthma as well.
Yeah, I've thought about that, and most of my colleagues have just said, well, try omalizumab. If it fails, move to an anti-IL-5. But they're targeting different mechanisms.
Yeah.
It makes sense if you can get them approved that a small percentage of people could benefit from dual therapy. So,
yeah,
Jay, when you do the dosing, do you dose with both on the same day, or do you try to alternate it?
So we've been doing dosing on the same day just to, because the clinic visits, because we're doing the every 2-week omalizumab and then mepolizumab once a month. So if we had to alternate it, it would mean 3 clinic visits. So I believe I was reading, it's on the same day.
And you haven't seen any reactions to
There
getting
were-
those?
Not in the 3 charts I reviewed. I didn't see any adverse reactions. So yeah, and then the other thing we don't have this information is on these 3 patients, what would have happened if we stopped the omalizumab and just started mepolizumab? Is it that they were responding more to the mepolizumab, or is it the combination of the 2? And that's what I don't have the answer, and something that probably needs to be explored.
I heard one of them, though, left UW and is at Everett Clinic, and you're taking care of, and you couldn't get insurance for both, and she's deteriorated.
She's deteriorated quite a bit since they stopped the mepolizumab. She was able to get that at the U, but she wasn't able to get it outside the U. So she's still on Xolair, but she's not on.
So that's a little partial answer to your...
Yeah.
That question, Jay, is not directly related, but I have another patient who's a difficult asthmatic, and I was trying to figure out why she crashed. And by accident, I repeated an IgE level that was 500, and 4 weeks later it was 1,500. So do you know any other diseases other than this that would give you such a quick spike in IgE?
I know that the IgE in this disease can be affected by steroid treatment, so I don't know if the time course and kind of can at least go up and down with disease remission and flares. So, but not that I know of that the IgE changes so dramatically. Besides,
So did you measure the IgE on omalizumab?
This is a different patient. This isn't the one you've seen. This is another one that I'm trying to figure out. So no, they're not on omalizumab
Okay,
yet.
because you'll get false numbers. Yeah. You measure the complexes of IgE, anti-IgE, so you can't actually get an accurate IgE when people are on omalizumab. Good, all right. Who wants to go next? I think when Param is here, now we've got 3 anti-IL-5 drugs, all coming to the market, each with its pros and cons. I've sort of got my bias already as to which is the most effective, but Mike Weiss tells me that I'm wrong. They're all equally effective if you use them right. So I'll be very interested to see what Param thinks about the relative efficacy of the 3 drugs.
Okay, so we're going to talk some highlights from AAAAI meeting. This might have nothing to disclose, and again, just to highlight some key points from the AAAAI 2018 meeting. So again, as Dr. Altman mentioned, the entire session was, the entire kind of meeting was big on environments. So should we recommend environmental control? And again, based on current GINA guidelines, single measure environmental control is not recommended. They do kind of say multifaceted approach is reasonable. So Dr. Matsoy, during a plenary session, kind of went over this controversy, kind of presenting different clinical trials and the results of these trials. And interestingly, what she found is that positive results is mostly seen when kind of the intervention is done on children and when there was a significant reduction in allergen level. And the takeaway message from kind of the entire session was, if you want to evaluate these clinical trials, you should not only evaluate intervention and outcome in asthma, you should evaluate intervention and what happened to the allergen level and then the outcome in asthma. Now, again, continuing the environment, so Dr. Gennaro actually addressed different aspects during kind of the continuous climate change and allergic diseases, and he discussed a little bit about thunderstorm, how does it increase asthma and allergic rhinitis. And
Taha, before you get into that, what did she show was most effective then to get the greatest allergen reduction? Was there an intervention? Was it?
It was like going over multiple clinical trials. You know, there is no specific interventions, like just saying, like for instance, this trial trying to control this type of allergen. However, there was no measures of how much allergen was reduced. And then they said, oh, this intervention didn't improve asthma outcome, so probably we shouldn't recommend it. While in other trials, they kind of documented how much allergen was reduced, and if it was less than more than 50% reduction.
But did she highlight what that was? Like, you know, she's done a lot of her work in the inner city with rodent exposure.
She has definitely highlighted mouse. That if
The
you're
mouse.
effective in reducing mouse, which probably is not as relevant here in the Northwest as the inner city Baltimore.
Yeah, we tried. Children's tried to recruit her, but her study population in Baltimore, New York, was like 50%, 60% of the homes had significant rodent exposure, and then she looked in the Northwest as like 1%. You know,
We don't have
2%,
cockroaches
so
and we don't have rodents, so
she couldn't do her research here.
What about dust mites, though? I mean, you think that would be relatively easy to measure, and we've always been told that intervention is the most important thing. So that falls into the same category. Dust mite controls don't work either.
Dust mite control. There was a paper last month from Jackie in Practice, and they said it really works. It's a great article. That's the most good evidence that I found for dust mites.
the problem is what Taha is pointing out. We tell people what to do. We never know how effectively they do it, probably not well. So if you don't know how effectively they do it, tracing that, we just, in open practice, we have no idea what we're accomplishing. But what I mostly took away was from when people do try and monitor dust mite efficacy, it's not very good. I mean, that's the Europeans basically say there's no value.
So, and again, how thunderstorm increases asthma. So thunderstorm apparently increases, because of the increasing humidity, there will be increased release of pollens and hence higher asthma attack. And kind of actually the speaker cited increased asthma attack in Melbourne, Australia after one of the hurricanes or rainy season. And not surprisingly, patients who stayed indoor were not affected, and that the patient of the risk was higher in patients who were not adequately treated. So focusing on the presence and which environment we should live in, apparently whether pharma exposure protects against atopic dermatitis, and Dr. Cheryl Steman from University of Wisconsin explored these questions. And what she found is that farm-raised children have more diverse microbiota and less risk of atopic dermatitis. And her conclusion is that a less diverse microbiota and early life depletion of Corynebacterium put the patient at risk of developing atopic dermatitis. So it seems like the microbiota is not only important for asthma, it's also for atopic dermatitis. And this is kind of very interesting. So it's basic science, but how the spectrum of allergic diseases is explained by only Th2. So we have anaphylaxis on one hand, which is mostly an IgE, and atopic dermatitis on the other hand, which is a type 4 hypersensitivity. It's delayed Th2 hypersensitivity type response. And we have the asthma and allergic rhinitis in the middle. So how is it all explained by Th2? And Dr. Hiroshito Kito, actually from Mayo Clinic, doesn't think so. And he explored the role of follicular helper cells as a possible explanations. And he did a really nice study on mice. So what he did, he knocked down both the Th2 and follicular helper cells, and he measured IgE production. And so if there's no Th2 and there's no follicular helper cells, there is clearly no IgE. And if you transfer the Th2, he was able to achieve some IgE production, but IgE production was not maintained. While if you transfer the follicular helper cells, you will be able to maintain the IgE production. And so based on that, he thinks like it's not all Th2. Probably atopic dermatitis is mainly Th2, while on the other hand, anaphylaxis is probably mediated by follicular helper cells and IgE, and asthma and allergic rhinitis in the middle. And this makes sense, like Jay was just talking about dual biologics. So if you block IgE and you block IL-5, and asthma and allergic rhinitis apparently is working, while if you block IgE in atopic dermatitis, it's not. So I thought this was interesting kind of aspect.
So there was another session I went to on stopping the atopic march, which is really about, and the main thesis was atopic dermatitis often starts the atopic march in young children, and respiratory allergic diseases follow later. And there was some data that in kids with atopic dermatitis is something as simple as moisturizing very thoroughly so you have an intact skin barrier, at least in some people's hands, seems to be very effective in reducing the development of respiratory disease. I don't know, David, what you think about that as a pediatrician, but people were making an argument that this is important.
Right. Yeah, just making sure that the skin barrier is intact, because that's the way you'll get sensitized to aeroallergens or foods and that sort of thing. That's the theory.
Okay, so speaking of IgE, it seems like the affinity of IgE is all that matters. So James Jung, a PhD student from UC San Francisco, explored whether we can overcome the affinity, the low affinity, by providing more antigens. So if this is the dose response curve for high affinity antigen, whether we can achieve similar activation of basophils by providing more antigen of low affinity. And he did a really nice study, again, kind of from mice. So what he did, he sensitized these basophils, and then kind of he take them from the spleen, he kind of extracted them from the spleen of these mice, and he studied them in vitro, and he kind of loaded them with antigens of different affinity, and he was able to show that the binding was similar, yet the activation was different. So the degranulation of basophils was different. IL-4 production was also different. So it seems like the affinity of IgE is all that matters. The affinity of antigen is all that matters. And again, cytokine and anticytokine therapy in atopic dermatitis. This is like a nice talk. There was also a talk on pathogenesis of atopic dermatitis. And again, Dr. Emma Gottsman-Yaski from Mount Sinai kind of went over all the different biologics in atopic dermatitis. And again, she emphasized that anti-IgE is not working, and anti-IL-4, IL-13 seems to be working very well. But what caught my attention is a new biologics which blocks OX40 ligand, which not only suppresses the Th2 response, but also promotes T regulatory expansion. So, and here's the way I understood the OX40 ligand. So if you have these dendritic cells, and this is kind of the inactive dendritic cells for a reason or another, allergen or virus, and we have our friend the TSLP now activating these dendritic cells. These dendritic cells, one of the things that the TSLP induce dendritic cells to express is OX40 ligand, which is one of the TNF cytokine superfamily. And then this activated dendritic cells will go to the lymph node, will meet with a naive Th cells, and this will activate them, will kind of commit them to the Th2 pathway. But then these activated cells will express the OX40, and this interactions promotes expansion of Th2. This interactions also promotes the generation of memory Th2. This interactions also promotes the expansion of the memory Th2. And we know that because of atopic dermatitis is mainly a delayed type hypersensitivity. It's mostly dependent on memory Th2. You will have lots of Th2, and these Th2 will go to the skin and promotes an allergic inflammation. Interestingly, also OX40 ligand, OX40 interactions blocks the generation of inducible Tregs. So it's kind of literally kind of polarized the immune system toward the Th2 inflammations. And Leonard pharmaceutical company is kind of developing a new biologics. It's GRP 430, A30, and this kind of monoclonal antibody against the OX40 ligand. And what does it do? It not only blocks the interactions, but works just like benralizumab. It kind of promotes antibody-dependent cell-mediated cytotoxicity. So you will vanish all these dendritic cells. And when you do so, you will not be able to expand these Th2. You will not be able to generate memory. And you will also be able to generate more T regulatory cells. And these T regulatory cells will go there and will counter out the Th2 inflammation. Such a kind of an amazing idea. I think this will be explored. The phase 2 trial is showing promising results, and I think this can also be tried on asthma. I don't know about the side effects. I think the kind of OX40 ligands might need to be kind of be careful because it's kind of more ubiquitous in the immune system. Okay, continuing with allergic diseases about vitamins and away from the controversy of vitamin D into a new controversy of folic acids. Emily McGowan, actually she's a fellow from University of Virginia, explored whether in utero exposure to folic acids can result in food allergy. And she did a really nice study on the Boston birth cohort, and what she found is that in utero exposure of in utero exposure to folic acids might actually result in food allergies. And she attributed that to the unmethylated form of folic acids. And this unmethylated form is usually the results of exposure to high level of synthetic folic acids. So whether you pick and choose neural tube defects or food allergies, that's something to be answered. And away from allergic disease, talking about Th17. I love Th17 because it's like, I call Th17 the line of the immune system. Actually, even the transcription factor for it is R. So it's implicated in many of these inflammatory diseases like ulcerative colitis. Interestingly, we don't find them in the tissue. So Dr. Francisco kind of explored why we don't find them in the tissue. And interestingly, it's like he attributed that through his study to two kind of property of these Th17 cells, and I will just summarize his results. First of all, they have limited ability to expand, and he attributed that to poor T-cell receptor signaling, which is a result of increased expressions of IL-4 inducible G1, which kind of in a way or another block T-cell receptor signaling. It also has impaired IL-2 response because of increased expression of muscarine, which decreases which controls like STAT5 activity. The other property, which is kind of interesting, is the plasticity. So they kind of, once they are in the tissue, they convert to a non-classic Th1 by starting expression of a T-BET, the transcription factor for Th1. So we have like this what we call non-classic Th1, which kind of makes sense because what the Th17 do goes to the tissue, call the neutrophils, and then once we digested everything, once we kind of phagocytose everything, we want to digest it, so that's kind of promotes Th1, which increases intracellular killing. So, and this kind of the end of the some highlights. So I have some takeaway message. If people were to live in farm, I think we will run out of business. Rainy Seattle means good business after all. And we may have to focus on more than one cell. We always love the Th2, but I think we should think now beyond that. If there is a follicular helper cells, there is the T regulator cells. And also we're having more therapeutic options over time. And the anti-OX40 ligand seems promising in atopic dermatitis, and I think should be tried also on atopic and asthma. Th17s are very efficient, yet they disappear like a ghost. Thank you.
Very good. You know, the only concern is we obviously evolved this complex immune system to be beneficial and therapeutic. So you block too many of these signals, there's got to be a downside. Yeah.
I'm not going to go over quite as many things as Taha did. I'm going to talk about three main presentations that I went to. Oh, someone had a disclosure slide for me. I have no disclosures. So the first presentation I can talk about was on Friday. It was titled Distinguishing Allergic Drug Rash and Viral Xanthoma. Was given by Dr. Ben-Chershon from Montreal Children's Hospital. And he started his presentation going over two cases. The first was a 12-year-old girl who was referred after receiving amoxicillin in the setting of an EBV infection and developing a rash. The second was an 18-month-old boy who was treated with amoxicillin for otitis media. Then after a week, he developed a sort of serum sickness-like reaction with rash, arthralgia, swelling of his feet, and fever. And he was referred for the possible serum sickness-like reaction. So just to sort of quickly review the four different types of allergy. Type 1, IgE-mediated, usually occurs within an hour of exposure. Type 2, hypersensitivity, is antibody-mediated cell destruction. An example would be HIT. This occurs days after the exposure. Type 3, hypersensitivity, is immune complex, usually IgG binding to a drug, leading to low complement levels and complement activation. Some examples are serum sickness, vasculitis, or drug fever, and this also occurs days after exposure. The drug. And type 4 hypersensitivity is T-cell mediated, example being Stevens-Johnson or 10. So then he reviewed a paper and study that he was on looking at graded oral challenge to amoxicillin in children who were referred for possible amoxicillin Allergy. So the children were referred to the Montreal Children's Hospital between 2012 and 2015. There were a little over 800 children who were involved. The history questionnaire was given to their parents regarding the previous reaction and what had happened in the past when they were given amoxicillin. They excluded patients with a history of Stevens-Johnson or TEN or symptoms consistent with anaphylaxis. It sounded like most of the children had a rash, but he didn't go over exactly what all the different reactions were. So then they gave an oral graded challenge with amoxicillin that was weight-based dosing. First they gave 10% of the dose, waited 20 minutes. If there was no reaction, they gave 90%, the rest of the 90% of the dose. And then of the children who were positive to the oral challenge, they brought them back 2 to 3 months later and did penicillin skin testing. And then they followed the children for 3 years to find out whether they subsequently were given amoxicillin, and if so, what reactions they may have had. So out of the 800 some patients, 94% were able to tolerate the oral challenge. Of these, 55 went on to receive amoxicillin again within the next 3 years, and 6 of those patients had delayed reactions, and I believe none of them had immediate reactions. 2%, so 17 patients in total, had an immediate reaction. All were mild and consisted only of hives. And of the 17 patients with an immediate reaction to the graded challenge, only one of them had positive skin testing, the pre-pen. And then almost 4% of patients had a delayed reaction. So going back to the 2 initial cases, the 12-year-old girl with a rash in the setting of EBV and amoxicillin, her oral amoxicillin challenge was actually positive, implying that it was really the amoxicillin and not necessarily the EBV infection. In case 2, the 18-month-old boy who had the serum sickness-like reaction, his oral amoxicillin challenge was negative, and he actually tested positive for influenza, and presumably his reaction was actually from viral reaction rather than the medication itself. So his takeaway points were that viral xanthums can mimic drug reactions, and it's really difficult or almost impossible to tell the difference just based on clinical history or looking at a rash, and that oral challenge is really important to distinguish the two. The second takeaway point was that self-reported history is not a reliable indicator of true risk of the reaction. And then the third takeaway, as I know we've talked about in previous journal clubs, is that most patients with a history of reaction to a drug can tolerate it and will have negative either skin testing or oral challenge. So the second presentation was on Sunday. It was titled "Occurrence of..."
Just back to that. So the unusual thing they did there was they didn't skin test; they just challenged.
Yeah, they did skin testing afterwards, not before.
But that's sort of the opposite, I think, what we
I was
would do in
wondering why they
practice in
didn't do
this
it
community.
prior. Did you explain? Or?
They didn't explain why. I think they were trying to find out. Well, I don't know. They didn't say.
See why you wouldn't do it before and after.
Takes 30 minutes.
Yeah. I mean, so they excluded patients with anaphylaxis, so presumably they were all sort of fairly low risk to begin with. But
still,
yeah.
Well.
Okay.
So the second presentation was on the risks of systemic allergic reactions or oropharyngeal swelling with house dust mite slit therapy. It's given by Dr. Bernstein at the University of Cincinnati. So allergen immunotherapy can result in systemic allergic reactions and anaphylaxis, and severe oropharyngeal swelling in the mouth or throat as a theoretical risk, obviously of airway compromise. And 50% or more of patients on SLIT can experience oral reactions at the first tablet intake. And so the point of this study was to really look at what the risks are of either oropharyngeal swelling or systemic allergic reactions in patients receiving house dust mite sublingual immunotherapy. So he reviewed, so there were 2 different trials, and then they combined the results of both trials in the end to get sort of an overall incidence of the risks. So the first trial was conducted in North America, and there were a little over 1,400, almost 1,500 patients. The second trial was in Europe, and there were almost 1,000 patients. Both trials had similar inclusion criteria. Patients had to have a history of allergic rhinitis with sensitization to house dust mites. With good respiratory status, FEV1 over 80%. There were slightly different age inclusions. The first trial, they included ages above 12, and the second trial was just adults, so age 18 and up. The first trial, the patients were randomized to placebo versus SLIT for 12 months and then had 8 weeks of follow-up. In the second trial, patients were randomized to placebo or 2 different dosing regimens of SLIT, but they only looked at the placebo versus the high dose, the 12, and then just to mention the first trial, the SLIT that they were given was also the higher dose. So from the first trial in North America, out of the 1,400 patients, there's one report of a systemic allergic reaction. It occurred on the first day within minutes of being given the first tablet. The patient developed itchy palms, facial flushing, shortness of breath, and throat swelling, and was given epinephrine with resolution of symptoms. There was one report of nasal edema, nasal swelling, which occurred on day 66, and that patient was able to continue treatment. He didn't actually mention whether the first patient continued treatment or not. From the second trial in Europe, there were no reported systemic reactions, and then there were 2 oropharyngeal swellings, so one was lipedema and one was mouth edema. The first occurred on day 274, so almost a year into the therapy, and the second one was on day 15, and both these patients discontinued the treatment after their reaction. So combining the overall results of both studies, there was one systemic allergic reaction giving an overall incidence of 0.1%, and 3 reported oropharyngeal swelling giving an overall incidence of 0.3%. He said that there were no reports of airway compromise, anaphylaxis, shock, or death. I will mention that even though he says there was no anaphylaxis, that first patient who had the flushing, the shortness of breath, the throat swelling, and was given epinephrine, which sounds like anaphylaxis, and he didn't really have a great explanation as to why they didn't consider that anaphylaxis, so take that with a grain of salt, I guess. So his overall takeaway points were that severe systemic reactions and severe oropharyngeal swelling can occur with SLIT, but it's rare, with an overall incidence of 0.1 to 0.3%, which is consistent with other literature. Reactions can be managed with sort of conventional treatment for reactions, and overall it's well tolerated, and the risk profile is appropriate for at-home administration. The other thing is just that I noticed is that the 3 different patients who had reactions, they really occurred at various times. I mean, one was on the first day, one was on the 15th day, and one was almost a year into treatment. So it's not just necessarily on the first dose, but really any time in treatment, patients can have a reaction.
So it leads to the discussion of what are we doing in this community. So I think if NAC, they give them the first dose in the office, wait a half an hour, and people are supposed to then have an epi injector, everybody who's put on this. Is that what we're doing in the community? Yeah. Anybody have a bad reaction with anybody?
Well, this was dust mite, right?
Yeah.
What's the comparison with grass?
Yeah.
Did they discuss that at all?
He didn't discuss that. This was just us.
I mean, that's been...
Yeah, nobody's on oral house dust yet. Or
well,
is it just
the
out?
Maybe just starting. I don't have anybody on it.
That's a good grass stick.
Of the 2 grass products that are on the market, I mean, it's interesting. I think neither of these products took off. I mean, they've had a very small uptake in the U.S., which is why Merck gave up on the product and it went back to ALK. So compared to Europe, these drugs have done very poorly in the U.S.
So the third presentation that I'm going to go over was looking at the risk of systemic reactions with subcutaneous immunotherapy. It was given by Dr. Sani, who's a resident at NYU Winthrop. This study that she discussed was a 10-year retrospective chart review of 450 patients who received SCIT between 2005 and 2015. And patients were categorized by age, so children age 5 to 15, adults 19 to 64, and then 65 and up. They excluded patients receiving rush or venom immunotherapy, and they classified the reactions according to the World Allergy grading system. Just sorry, I know this is small, but just this is a overview of the WAO reaction grading system. Just get it goes from grade 1 to grade 5. Grade 5 is death. Grade 1 is the most mild, and it sort of goes up from there. Their patient characteristics, so almost 75% of the patients were adults, 20% were pediatrics, and 7% were age 65 and up. There was slightly more females than males when they looked at their patients. There was a total of 74,000 injections, and I calculated it. So based on like 400 some patients, it sort of breaks down to approximately, if each patient was on 2 different immunotherapies for 5 years, that sort of adds up to 74,000 injections. And out of that, there was 177 systemic reactions, and a systemic reaction was identified in almost a quarter of patients. The vast majority of reactions were grade 1 or grade 2, so 98%. There was 1%, there was grade 3 and 1% grade 4, and there were no grade 5, which is death. So. And then systemic reactions were associated with female gender, history of food or drug allergy, and then patients receiving immunotherapy to PET or dust mites. And history of asthma wasn't associated with the risk of systemic reactions.
You know, the PET or dust mite is, to me, paradoxical. I think people with pollen allergy, especially grass, would have the most severe reactions.
They didn't.
Not what I would have thought the data would show.
That was the old data.
The old data is clearly grass. The other risk factor that always comes out is asthma. The second point there doesn't fit with previous data.
And they didn't say in the patients who had asthma and who had a reaction whether their reactions were more severe. Just history of asthma in general wasn't associated with overall systemic reactions. So I don't know about that. And then the vast majority of reactions were during the build-up phase. Only 3%, so 6 reactions out of the 177 were on the maintenance. So half of patients who had a reaction went on to have a subsequent reaction in the future. Although most of those patients, out of the patients who had a subsequent reaction, most of them were either similar severity or less severe, over 80%. 12% were more severe, and then 4% had multiple reactions, and some were more severe and some were less severe. So her takeaway points were that the incidence of systemic reactions is low. They found 2.2%. There's an increased risk of systemic reactions with female gender, history of drug or food allergy, and then receiving immunotherapy to PET or dust mite. Almost all reactions were grade 1 or 2, so mild. There were few high grade, but no fatal reactions. And then overall, it's safe and effective for all age groups. The other thing that she mentioned was that there was no difference in incidence between the different age groups. So between the adults, pediatrics, and seniors, they all had the same incidence of systemic reactions as well.
Now you're saying serious systemic reactions, because what, didn't you just show that was 24%?
So
systemic?
24% of patients they found some systemic reaction, but most of them were mild.
And that's, so the incidence of severe systemic reactions was low.
Oh, yeah. Sorry, yes.
Yeah, you left the
yeah.
word.
Yeah.
Severe.
So I'm just curious, of those in the room, since the introduction, the whole point, or 2 of the main points of oral is fewer reactions and you can treat yourself at home. Any idea what percentage of your patients you have on SLIT? I have few. Maybe, I don't know, 1 or 2% of people on immunotherapy.
What I've noticed is I start people on SLIT, and then the question is a lot of them never come back for the second year. So I don't know whether they think they're cured or they just gave up.
Well, people have tracked that, and when I first heard those numbers, you would think if you told somebody you can do this at home, and maybe you just have to see me once a year to renew the prescription, the uptake would be good. But the European data was like under 20% of people stick with it. it's no better than what we accomplished with subcutaneous. And so that advantage has disappeared. People are just lazy or not interested. It's interesting to me that this empiric therapy that people worked out 100 years ago, it's only now, with some of the newest biologics, that we finally have some other therapies that are as good as this, or maybe as good as this. You know, just philosophizing here, before anybody understood IgE, understood the whole mechanism of allergy, they just thought they were immunizing people like smallpox immunization. They worked out a therapy that's fantastic. And I'm always amazed when we see data saying that immunotherapy makes people 20 to 30% better. Because when I'm in a room with people, I tell them it's going to make you 70 to 90% better, which is purely just my made-up data. It has no verification. But don't you think that's true? That you see people who get remarkably better? Now, of course, there's the placebo effect, which gets factored into that because you're not giving the other guy in the next room placebo. But I don't think we've worked out anything better yet than immunotherapy in our field.
Subcutaneous immunotherapy promotes T regulatory cells, that's kind of exceptional. All other interventions.
Well, don't confuse us with mechanism. This is just, I'm just teasing. It does work remarkably well.
I'm still amazed that the Europeans keep finding these monosensitized people.
They don't.
I never see those
people. They just ignore the rest of what people. That's Hal
I feel
Nelson.
better.
They just pick the dominant allergen, or at most two allergens, and they more or less ignore the rest of their sensitization.
Because I can't find these monosensitized people that they keep talking about.
Even there's monosensitized. So there's like a talk also at Quad AI looking into the mechanism of subcutaneous immunotherapy, just like studying this, because so far we don't know exactly how this works. And it seems like it promotes like IL-10 production, and IL-10, regardless of the specificity, can kind of suppress any allergic inflammation in general because it controls the Th2. So if you kind of have immunized someone for dust mites, he's also allergic to grass. By virtue of immunizing to dust mites, you probably also suppress the Th2 response to grass indirectly, though not specifically.
Although the early studies before those mechanisms were understood, years ago, the studies out of Hopkins on, say, ragweed immunotherapy showed specificity that you reduce symptoms during the ragweed season, and it was not non-specific in a clinical outcome. It didn't reduce their symptomatology out of the ragweed season. So the other thing, I didn't ask Steve Durham this, but when the Europeans find that oral immunotherapy is as effective, I don't know if, say they're just treating people with grass immunotherapy, if they're only monitoring their symptom reduction during the grass season and not asking, are you better during the tree season or during, like here in the U.S., the ragweed season. So when they're saying it's efficacious, they're not looking at 365 days out of the year. If we immunize people for grass and tree, and in the East Coast ragweed, that's like 8 months of the year that they're having symptom reduction. If you've monitored their symptoms over the whole period, would you do better with subcutaneous immunotherapy? And it's not a head-to-head comparison if you follow. I don't know how they're actually recording the data.
And the fact that they stop it for 6 months out of the year, I mean, from what we're doing with subcutaneous, I mean, we're counting on that time period to continue an immune response, and they're just basically dropping it for that 6 months. And I never understood that, why they would do that.
We don't have to. I mean, their data shows if you continue grass 365 days a year for 3 years, you get a carryover effect of protection for the next 2 years.
When you try and get that through their insurance company, they say, no, we'll give them 6 months, and they're off for 6 months. And
well, getting the drug approved by insurance anyway at all is a problem. Well, we've actually stopped giving the first dose with a sample in the office, because after you achieve that, then they go out to fill the prescription and get denied, and you've accomplished nothing. So we want to make sure that approval before you even do the first dose. Next week, I think we have a guest speaker from Genentech talking about Taha's favorite, basic science.
Has anybody tried tried Allergy, just regular subcutaneous immunotherapy with Xolair? It's just like a rush immunotherapy for just regular shots with Xolair as the underlying treatment.
They've done it with food. Yes, they have.
Yeah, they
Well,
have.
With
that has
grass
been
or
done.
dust mites or anything like that?
Yeah, it's been done with conventional,
But
and
that's
it basically allows you to get, people have done it to get rush done a lot faster.
Right.
Yeah.
But I never saw anything more about that. So now that with the Xolair and peanuts and stuff, I thought maybe they'd resurrect a lot of that other Xolair stuff, but haven't seen any of that. Uh-oh. Extend meeting.
All right, well,
No.
I didn't pass around this picture of fun and games for those who didn't go to the meeting.
I can't tell who the people
Who's
are.
who? Frank, Petroni, William, Matt,
Yeah.
Eileen,
Well,
Jay
either
Patel.
way, it'll get taken care
Where
of.
are you?
I'm here with this dour look on
Is
my
that you?
face.
Okay. Well, the best way
The
is
lighting isn't the best. With a very nice group picture there.
All right, well,
Actually, you know what I'm impressed with?
It
I
might
think
be a
that
different answer.
I'll do that. I'll just put attention. Dr. Like it right.
Alaska.
Yeah, I go there.
Huh?
yeah,
so that's still the best.
maybe 10% of people need it.
I met Karen and at the allergy conference.
Dennis, is it tomorrow or is it today or Wednesday? Is it tomorrow? The rematch?
Yeah.
What are you talking about?
Chelsea Barcelona. We're talking about soccer.
Oh, good.
He knew exactly what I was talking about when I asked him, though.
Do I need to take my name?
Is this,
Well, let's pack this
Because
up.
right
after
now,
we
it's
get it
always
out
a
of the room.
crapshoot whether.
Dr. Altman, do you know, is the mouse part of the group?
Yeah, it's ours. I think I brought it.
Okay.
Mike, you need some food for the road?
They'll usually just get-
We got it?